Good morning, everyone. It is indeed pleasure to invite Dr. Krishna Mori, who is resident doctor from Endocrine Institute from Chennai, and he is presenting evaluation of value of fasting plasma glucose in the first trimester for the prediction of adverse pregnancy outcomes. From the article is from Diabetes Care and Diabetes Research and Clinical Practice Journal, and we have Dr. Krishna Mori presenting, and this article is from recent journal published in April 2021. Yes, Dr. Krishna Mori, you can share the screen and
yeah.
go ahead with the presentation.
Yeah. Good morning, everyone. At the outset, I would like to thank Dr. Mayur Patel sir and Dr. Yashbhai for giving me this opportunity. The article given to me for this month's MDR is evaluation of the value of fasting plasma glucose in the first trimester of pregnancy for prediction of adverse pregnancy outcome. It was done by a group of Chinese researchers and was published quite recently in March 2021 in Diabetes Research and Clinical Practice. As we all know, the gestational diabetes has been on the rise throughout the world, and it has been closely following the trajectory of obesity and metabolic syndrome. Along with that, as endorsed by IAIDPSG and then subsequently by WHO and ADA, for screening for GDM, we follow a 2-hour OGTT, 75 gram 2-hour OGTT, which is generally done between 24 to 28 weeks. However, in the last couple of decades, there has been few articles which has been proposing the role of fasting plasma glucose in the first trimester for screening of GDM. However, there has been many other articles which has refuted this notion. But what is this article? What this article brings the novelty is that it shows the role of fasting plasma glucose in first trimester beyond screening for GDM. The aim for this study was to evaluate the importance and usefulness of the fasting plasma glucose in the first trimester in predicting the adverse pregnancy outcomes in the perinatal period. The methodology was it was a retrospective study which was done in 3 hospitals from China. Around 44,000 pregnant women were screened, and 22,398 singleton pregnancy were included. The inclusion criteria was live-born singleton infants, fasting plasma glucose value which was available in the first trimester or less than 14 weeks of gestation, and complete maternal and infant records were required. The exclusion criteria was the women having pre-existing diabetes, chronic hypertension, any other missing data, especially of the pre-pregnancy weight, height, 75 gram OGTT data, PIH diagnosis, birth weight, and gestational age. So out of these around 22,000 odd women, they subdivided these women into 3 groups. That is, the first trimester fasting plasma glucose was measured, and they divided into low fasting plasma glucose, medium fasting plasma glucose, and high fasting plasma glucose, based as less than 92 milligram per deciliter, 92 to 101, and 101 to 126. These 3 groups were further substratified at the second trimester when they did a 75 gram OGTT into positive and negative, that is, the patients who were diagnosed to have GDM and those who were not diagnosed to have GDM. So coming to the first result, this table is showing the comparison of the incidence of pregnancy outcomes in women with normal and abnormal OGTT at different first trimester fasting plasma glucose. So as we discussed in the last slide, these are the 6 groups they have divided: women having normal OGTT and women having abnormal OGTT, which were again subdivided into women having low, medium, and high fasting plasma glucose in the first trimester. And what they have tried to look at is these 6 parameters during and after the pregnancy in the form of PIH, cesarean section, macrosomia, large for gestational age, small for gestational age, and preterm birth. The first group, that is women having normal OGTT and fasting plasma glucose less than 92 or 92 milligram per deciliter or 5.1 millimole per liter, has been taken as a comparative group here, and they have tried to compare whether there was any statistical significance between these 5 groups as compared to this first group. As we all know, women with GDM has higher propensity of all these six adverse outcomes, It was also shown in this study. As we can see, most of the values were statistically significant. However, these are the two values which were of more importance in this table, being macrosomia. So macrosomia in women having medium fasting plasma glucose was higher as compared to that having low plasma glucose, and PIH for women having higher fasting plasma glucose was higher as compared to that of women having low fasting plasma glucose. Coming to the second outcome of this study, this is the table showing odds ratio for the association between fasting plasma glucose categories during the first trimester and pregnancy outcomes in women with a normal OGTT. Again, the 6 outcomes they have taken. On the here we can see that they have taken women having abnormal OGTT as the reference year. So they have combined all the women having abnormal OGTT or women diagnosed to have GDM, and they have tried to compare the other 3 groups. That is, women having normal OGTT with low, medium, and high fasting plasma glucose with that, and they have tried to analyze what were the odds of women having normal OGTT with low, medium, and high fasting plasma glucose in the first trimester. What were their odds of having these 6 abnormal parameters as compared to that of women having abnormal OGTT? So in this, women having high fasting plasma glucose with normal OGTT had a higher odds of PIH as compared to that of an abnormal OGTT or GDM women. Women having medium fasting plasma glucose had almost same 1.02, that's almost same odds as compared to that of women having GDM of macrosomia, and women having low and medium fasting plasma glucose who are not diagnosed to have GDM had higher odds of having short for gestational age babies as compared to women having GDM. And coming to the final outcome, this is a table which is showing odds ratio for the association between fasting plasma categories in the first trimester and pregnancy outcomes in women with a normal OGTT, which was stratified based on BMI. So this is actually extension of the previous table. As we can see, the 6 outcomes are there here, and they have substratified the women having normal OGTT with low, medium, and high fasting plasma glucose into further 2 groups in each of these categories, that is BMI less than 24 and BMI more than 24, and they have tried to compare this with women who had GDM or an abnormal OGTT. So here we can see is that women having low fasting plasma glucose with BMI of more than 24 kg per meter square had a higher odds of having PIH, cesarean section, macrosomia, large for gestational age and small for gestational age as compared to that of women having GDM. Similarly, women having medium fasting plasma glucose but BMI more than 24 kg per meter square had higher odds of all these 4 as compared to that of women having GDM. Women having higher fasting plasma glucose with normal OGTT again had with BMI more than 24 had higher odds of having these 4 adverse outcomes as compared to GDM women. Coming to the critical appraisal, the strength of this study was the number of participants. They have taken more than 20,000 participants. In the literature currently, there are fewer studies which are evaluating fasting plasma glucose in the first trimester of pregnancy with early perinatal outcome in women with normal glucose tolerance. And the last table, which is showing the sub-analysis based on the BMI cutoff, is revealing. Actually, it's quite revealing. However, the limitations of the study being it being a retrospective design, and as it is a retrospective study, we can get association and not causation. And as we know, association and causation are quite different things. Also, a large number, almost 50% of participants were excluded, and hence there was a probability of inherent risk of selection bias. And they also, as we saw in the second and the third table, they have grouped all women with abnormal OGTT or GDM. So we don't know whether they were only on medical nutrition therapy, whether they were on any pharmacological therapy, and how was their control. So it was a large, it was quite a heterogeneous group to combine together. And the last thing, it was the Chinese cohort, as it was from the 3 hospitals in China. So we don't know how these results extrapolate to our Indian context. As we know, the Indian diabetic is different from the rest of the world people with diabetes. So to conclude, this study shows that high first trimester fasting plasma glucose can help to identify high-risk women early in pregnancy. BMI needs to be considered when evaluating the value of fasting plasma glucose in the first trimester. However, a large, well-designed, prospective and multi-center studies are needed to further confirm who would benefit from early screening of first trimester fasting plasma glucose levels and timely intervention in regard to pregnancy outcomes. Thank you.
Wonderful, Dr. Krishna Mori. And you rightly mentioned Indian population data as well as prospective study, and without causing the bias of, I'll say, the enrollment of the individuals is
Yes.
one of the key features to look for.
Yes.
Looking further into, like you rightly mentioned, what is the mode of therapy as well as how well the glycemic control is in those individuals, from where we are comparing. So what is their average A1C is not mentioned in the glycemic control is not mentioned in the article. So
Yes.
what could be the benefits, or how can we implement in the Indian scenario? That is one of the questions we'll put forward to the delegates. And if we have a chance, then we can work on how to create a methodology to the Indian perspective. But if we see the clinical practice, usually in Indian scenario, we always ask for fasting and postprandial, even
Yes.
for the pregnant female, and along with the glycemic control. So on that basis, we can take a note that how fasting, OGTT and A1C can be monitored prospectively, and accordingly the methodology can be built up. Yes, Indian data. Any inputs you would like to share with Dr. Krishna Mori to the audience and the participants?
No, as you rightly said, our Indian context has to be different from the Chinese context. And in resource poor settings, we sometimes use fasting sugars, especially for screening in first trimester, as you rightly said.
That's
So
true. And to the further extension, when you mentioned about BMI, it is better to notify that what would be the BMI or the weight at the start of pregnancy, and what would be the weight gain at the end of the pregnancy. But over time, that methodology can be built on further.
Yes,
And
yes.
this could be a relatively correlated or the combination study with the gynecological OBGY people and our consultant team. Yeah.
Yes, definitely. Yes.
Any more inputs?
No, I think that's fine.
Really appreciate it. Thank you, Dr. Krishna Mori, to be in the May episode of Metabolic Disease Review meeting. And we really appreciate your inputs and your dedication to present this article. Everyone, thank you. And you can post your questions in the chat box for the further things.
Thank you.
Yeah. Take care.
Okay.